Shall I just press the green one? Thank you. I have a stinking cold as well, so bear with me if I kind of lose my voice at some point or you can't hear me, because someone just kind of lift their hand and I'll try and raise it a little bit. Thank you for inviting us to speak today, I think is how I should start that. Hopefully this will give you a bit of an overview of the NICE guidelines, save you having to read all those hundreds of pages that go with NICE documents these days. So the idea of NICE starting to look at the diabetes was to look at all of the aspects of diabetes together, so that when you now go on the NICE website, it won't just give you one set of guidelines, it will give you a flow diagram that actually encompasses type 1, type 2, the diabetic foot, pregnancy, all as one flow diagram, so you'll hopefully go through one set of guidelines to another if that's an area that you're interested in. Excuse me. And hopefully they will all now marry up. So actually what we've got historically was one set of guidelines set one set of targets, and another set of guidelines, because they were written afterwards and there was new evidence, set different targets. So hopefully they're all now a more cohesive structure. So the guideline that I was involved with was the care of the diabetic foot. And writing that guideline, I thought was going to be quite a simple process, but actually didn't quite turn out like that. As clinical experts, we were asked to apply for the NICE job, and you had to do that by putting forward your CV, and then you had an interview. So only those that they felt had got enough to offer to the group were actually invited to become members, and I'll go through who the members of the group were shortly. There was also patient representation on that group as well, because obviously it's vitally important that we actually get their perspective and not just ours as healthcare professionals, because ultimately it's the patients that have a knock-on effect. And for every one of us that was round the table, there was a NICE member as well, and there seemed to be as many NICE members as there were us in every meeting, and it never ceased to amaze me the different faces and expertise that they brought to the table, and actually made it quite a conducive job. It was certainly a journey, writing the guideline, and one at times which offered frustration, because reviewing the evidence, as we'll look at later, wasn't always as straightforward as you thought it should be, and often what we deemed to be good clinical practice was very little evidence base behind it, which I'm sure you'll find in some of your own clinical areas. But it also meant that for 18 months we were to and from Manchester, sometimes for 2 days at a time, sometimes for one, which also takes you away from your clinical practice, and there's no backfill or funding for that. So it is a big undertaking. There's also no payment for being part of a NICE group. It's just one of those that you put on your CV. So we'll look at a little bit about who's involved within that. So we had diabetologists on the group. We also had paediatrician diabetologists, because it was a document that goes basically through the whole journey of diabetes. Podiatry, I was the token nurse, and I think within the diabetic foot, there's probably not many of us that have a specialist interest in it. Vascular surgery, microbiology, orthopaedics. We struggled to get orthotics, biomechanics to actually have a member representation, because part of NICE, you have to declare all your other interests and other things that you've done. And most orthotic companies are actually privately subcontracted into the NHS, so there's a conflict of interest. So they were only actually asked to come in and pass their clinical expertise on key issues, and then asked to leave the room when we made our recommendations, which was an interesting process. Again, we struggled with the radiologists, because there's not many radiologists that have a keen interest in the diabetic foot. There's lots that report on it, but again, it's an area. Casting was something that we covered, and we also had a tissue viability nurse that just opted in for the sessions that were applicable to her. So when we looked at the guidelines, we looked at the key priorities to actually implement this guideline. And what it was trying to do is pull two guidelines together, because we had the type 2 care of the diabetic foot, and we had CG119, which was the inpatient. And we weren't asked to actually comment an awful lot on CG119, because that was already deemed to be a document that was in process. We could only sort of tweak that, but it was to sit alongside. So we'd got a cohesive guideline that took someone from a low-risk patient to someone who was admitted or developed a problem whilst they were in hospital. Quite importantly as well, we looked at care across all care settings, assessment and risk of developing a foot problem, diabetic foot problems, infection, and Charcot Arthropathy. And Charcot Arthropathy was something that wasn't in the previous guidelines in any way, shape or form. And when we first sat round the table as a group, and they gave us the topics that we were going to be exploring. Charcot wasn't one that was actually there. And it took quite a lot of persuasion, I think, from the NICE team to actually get it included, because that then meant extra time that we needed to discuss this key area. But as healthcare professionals, we felt it was vitally important that it was discussed, because it's often the forgotten gem within the diabetic foot. So when we looked at care across all settings, we had to look at training and competency. And with all of our roles, it's a key ongoing issue for all of us, because training somebody is the easy thing, but getting them to that level of competence and confidence is another thing that's actually, it can take years to get somebody to those levels. And you seem to get people up and running, and then unfortunately they seem to leave and find pastures greener. So it's an ongoing worry with that. We're also very mindful that actually we need to make arrangements for people with disabilities that don't access healthcare as well, and that might be your IV drug users, it might be your homeless, it might be those with mental health problems, but they're often individuals that do far worse, and it's how we can try and reach out to those individuals to ensure that they also get the care they require at the point that they require it. And then obviously everything in the healthcare now is it has to have a pathway attached to it, so we were pathway driven. So we were pathway driven to looking at integrated pathways between the screening services, the foot protection service, the MDFS, and then also how we then incorporated that with footwear and orthosis as well, to actually try and keep these individuals either ulcer-free or preventing them occurring further ulcers. So when we're looking at risk assessment, it comes into multifactorial things when we're looking at the diabetic foot, because it doesn't just fit into one problem. There are often several factors when we're assessing the risks that cause the problems. So it's not just neuropathy that causes a problem. They've often got multi-factors that we're having to try and juggle to ensure that these individuals either don't ulcerate or that we can keep them ulcer-free. But we also had quite an interesting journey. Because my background is adult nursing, I have very little understanding, I suppose, of what happens in the paediatric service. And the joys of having a paediatric diabetologist on the group was actually she was able to enlighten us on what happens. And unfortunately, it appears not a great deal, because children under the age of 12 are just given basic foot care advice by the diabetologist. Now, bearing in mind someone could be diagnosed at the age of 2 with type 1 diabetes, they've obviously got a lifetime of complications that could possibly occur. And we certainly, within my setting, have seen people referred earlier and earlier into our diabetic foot clinic. My youngest patient at the moment is 22. Now, they don't ever think these things are going to happen to them at a young age. But unfortunately, if you've had many years of diabetes with poor control, things do happen quite quickly. And they're often the poorest at attending because they have so many hospital appointments, or they perceive that they're actually invincible, because we're all invincible when we're in our teens and our early 20s, that none of this is going to happen to them. So young people have an annual assessment, and that again seems to be carried out by the diabetologists within the secondary care setting, rather than it being carried out in primary care. So it's also, I think, made us question our own practice and think about how we need to upskill some of these young individuals about understanding their risks so that they can deal with them better. When we look at the adult service, we're looking for people to have screening of risk for their feet at diagnosis on an annual basis, admission to hospital, or if they're a change in their foot status whilst they're an inpatient. Because obviously, as we know, things can change quite quickly. And I'm just going to go through some of those risks and how they actually affect patients and what we should be doing to actually assess those risks. Excuse me. So neuropathy obviously requires quite careful evaluation, because once you've diagnosed someone as neuropathic, you can't take it back. We know that actually age and duration of diabetes will increase the likelihood of getting neuropathy, and that 50% of people with type 2 over the age of 60 actually have neuropathy. So it's something that's very, very common. It's how we educate those individuals and how we treat them that's important. So sensory neuropathy is when they get tingling or numbness, loss of ability to feel or detect changes in temperature. They can sometimes become quite uncoordinated because they're not sure where they plant their feet as they walk. Or some people will get neuropathic pain, which will be the burning, shooting pains, which is often worse at night. And it's trying to educate people about not walking around barefoot, sharp objects in their shoes, if they can't see their feet very well, and often people that have got neuropathy will have had quite a lot of eye damage as well. Friction from poor fitting shoes is the bane of my life, and burns from radiators and hot water bottles. And I'm actually looking after a gentleman who we discharged on Monday, who is not known to the foot service but was admitted with a burn from his foot, who's actually ended up having his foot amputated as a result of a burn. He's 51. It's something as simple as that actually once it happens, if it gets infected, things can go wrong very, very quickly. So we looked at how you check for neuropathy. So monofilament came out as something that we could recommend, that was a tool that you can use to assess neuropathy. However, when we looked at it, the variability of how many sites should be used was quite variable. The gold standard seemed to be 10, but some places were using as little as 4 and still being able to detect neuropathy. So even though there's something we were able to recommend, it didn't come with a gold standard as to actually how many we should be doing. The touch the toes test, which is from Jerry Raymond in Ipswich, is something that I think we all probably utilise more than we would, because just pulling a monofilament out of your pocket whilst you're at work isn't something that many of us achieve, because it's not the tool you just have in your hand. And certainly trying to find it in an inpatient setting is virtually impossible. The touch the toes test is quite a crude but very simple test to actually check with the patient's eyes shut, obviously, because otherwise if you touch their toes and they can see you touching them, they'll give you, yes, I can feel it, because they wish to please you. Quite a crude way, but a very simple way that you can utilise in any setting to actually check if someone has sensation in their feet. Limb ischemia, obviously there is a nice guidance on lower limb peripheral arterial disease, and we've tried to link in the guidance that we've given for this new guideline along with that, and it was quite frustrating at times when we wanted to say things, but actually the guideline that already existed didn't quite word it as we wanted it to, because we couldn't change that, so we just had to work alongside it. Excuse me. So obviously the incidence of ischemia will be increased with diabetes, non-healing wounds on the feet and unexplained leg pain. Often these individuals will have claudication, and also it can go on to be actually critical limb ischemia. Examination of foot pulses is really important when you're trying to ascertain whether someone has got good circulation, but that can be really quite challenging, and in practice, palpating pulses on someone who's got quite edematous feet can be virtually impossible. Equally, if you've got a Doppler, that's all well and good, but again, it goes back to the training and competency of who is able to actually use that Doppler and how confident they are with it. We also talked about ABPIs and the need for careful interpretation in the diabetic foot because of calcified arteries. And I haven't got a laser pointy thing, but hopefully your eyes aren't too squiffy from your night out last night. You can identify that calcification, certainly on the right-hand picture going up the leg. If you try and compress these vessels, they don't compress as yours and ours would, because they're not flexible. They're quite rigid, so you will get an increased ankle brachial index result, which might not actually give you a true indication of how ischemic that patient is. And often a duplex scan is a preferred tool for these individuals for that very reason, because then you can actually see where the runoff occurs. So I'm afraid there's some horrible pictures now for those of you who had a heavy night. I'm sorry. So obviously gangrene, something else that we talked about, and the different stages of gangrene, because it's not just dry gangrene, it's wet gangrene, it can be critical limb ischemia. And certainly the foot on the bottom right is of less of a concern. We've got a nice gangrenous toe that we would hope will just continue to dry and eventually fall off. The one in the centre has obviously got wet gangrene, which is tracking down on the plantar aspect of the foot, which needs intervention, and it needs it now, it can't wait. The one on the top right is obviously critical limb ischemia. That individual actually is unlikely to keep that leg. It's not salvageable. We've gone past that stage. They're looking at an amputation, and at best you would be hoping for a below knee. In reality, he actually ended up having an above knee. One on the top left, you've got nice dry gangrene, which we would hope will continue to demarc and eventually come off. But all of these need intervention alongside this. They don't just need us to sit and watch and wait. They'll need vascular to be involved with whatever they can offer. And sometimes they can offer quite a lot, and we seem to pull off miracles. Other times we don't seem to quite achieve what we want to, because there is nothing else that we can offer for these individuals. If you've got ischemia and neuropathy, they're often your worst case scenarios, and the patients that are harder to treat. And I just wanted to point out, I suppose, how quickly peripheral arterial disease can progress. So this is a patient of mine who I saw at the end of December last year, who presented with what had been a blister from wearing 2 pairs of socks in his work boots. So we saw that on the 30th of December. We saw him a month later, and it had obviously significantly deteriorated. He was admitted at that point for IV antibiotics, and he had an angiogram, followed by an angioplasty, which they were only able to get circulation to just before his foot. 2 weeks after that, we felt reasonably confident. 2 weeks after that, we didn't feel quite so confident. Vascular hadn't really got much more they could offer for this chap at this time, so it was just a question of carrying on. Bone samples at that point showed sensitivity only to IV agents, so we got him on home IVs. And it did seem to sort of be holding its own. It wasn't really improving. But then it went south quite quickly, even on home IVs. And that's where we are at the moment. His sutures are due out on Friday. But we've got almost a sealed wound. There's a small area that is still open. Our hope for him now is that that will hold. Those sutures aren't going to come undone. And it's probably best case outcome for him because it is a toe and it could have been a lot worse. Time will tell. We've also put antibiotics into that wound to try and then help the long-term healing process because obviously there's a heavily infected wound there. But you can see from December to April how things can go wrong in someone who hasn't got good blood supply. It can actually go very wrong very quickly. It doesn't take much because that first wound, actually most of us will look at it and go, I've done not too bad. But actually because there is no blood supply, the disease process happens very, very quickly. Obviously, ulcer formation in a neuropathic foot often will start with callus formation. It'll start with a hemorrhage under the skin, breakdown of the skin, and then that can lead to deep foot infection and osteomyelitis. So these are just a selection of feet because we say ulceration, we talk about wounds, and we'll say they've got a diabetic foot ulcer, but that doesn't actually classify what we actually mean a lot of the time, and Catherine will discuss in her talk how we've actually, as part of NICE, tried to classify wounds because how we talk about wounds will be very different. How I describe the wound on the top right might be very different to someone who doesn't do much wound care, who's on the wards, that sees it for the first time. You get horror stories reported to you and you go and look at a wound and go, doesn't look too bad. Because it's what we're used to, it's what we see day in, day out. But somebody who doesn't do it day in, day out has a very different approach, and their description of the wound and their dimensions sometimes can be slightly different. So it is very important to actually be able to classify and categorise what we're actually talking about. So something as simple as callus in the top left can end up with deep infection and osteomyelitis. The one on the bottom right, I suppose for me is a good learning curve that actually they look like two very superficial wounds that didn't any sort of surrounding erythema, no swelling, looks quite nice, but actually the wound's connected and there was deep-seated infection there. So it's, I suppose, thinking about what else could be going on with this foot. Dressings. There is very, very little clinical evidence out there for the diabetic foot and dressings. In fact, what is out there is probably not worth a great deal either. Ultimately, it will come down to our personal preference and what we're used to using and what we're confident in using, and equally what the patient feels working for them. And it's trying to get that so that you're actually managing the exudate of the wound, you're managing the bacterial load, you're managing the actual keeping that as moist as we possibly can in the neuropathic foot, but in the ischemic foot we want to keep it as dry as we can until they've been revascularised. So it's sometimes a bit of a thinking game as to what we need to do for that individual in front of us. There's no clear-cut guidance. Basically, it's the cheapest dressing that will do the job, unfortunately. NICE does recommend VAC, or negative pressure, but only in surgical patients. So post-debridement surgically, VAC is used, and we do use it, normally for 2 or 3 weeks post-surgery. but it's on the recommendation of the multidisciplinary team rather than it just being that's what we should use for everybody. Diabetic foot infections. We also talked about how best to get a good sample, because if you just waft a swab over a wound, it is like using your magic dust. You're generally not going to grow anything. You need to get deep in if you can. If you can get soft tissue or bone, you'll get a better wound sampling and better sensitivities and specificities to actually antibiotics. There was lots of debates about antibiotics, and if you ask myself or Catherine where our preferred choices would start, they're going to be very different. So we've adhered to local guidance for antibiotic guidelines, always considering that osteomyelitis may be an underlying problem, certainly if the problem's been there for a while. If it is osteomyelitic, that a prolonged period of antibiotics is going to be required. X-ray to confirm your suspicions of osteomyelitis, and MRI if your X-ray is inconclusive. When we were looking at the literature, as I sort of alluded to earlier, you'd get the paperwork come through about a week before you were due to go and see your next NICE meeting, and it would say they'd had 9,783 abstracts, and you think, holy man, it's going to be a lot of reading on the train to Manchester this time. But then it would be dwindled down to only 45 of those were actually identified as appropriate. And of those, 37 didn't fit the inclusion criteria. So then there was 8 that you were actually looking at as articles. So the evidence out there is really lacking, and it's really frustrating when you're trying to write a guidelines, because the wording you can use is based on how strong the evidence is as to how much you can recommend that something is used. And often it was going back to our clinical experiences as a group to actually help try and word that so that it was useful for people to utilise as a piece of work moving forward. We talk about osteomyelitis and probe to bone. If you can see, I don't know how clearly that wound comes across, but it's quite a superficial wound. But when we probed it, you could probe all the way through to bone. So although it looked very almost pinprick as a wound and something that you generally wouldn't be too concerned about, your probe actually went in 3 centimetres. And if you can see on the X-ray on the right, the destruction of the bone as a result of what looks like a very clean, superficial wound, until you actually get your iron out and start probing the wound. So if you think that it could be deep, you need to probe it to actually check whether it does probe to bone. If it probes to bone, suspect osteomyelitis. And even if your X-ray doesn't show osteomyelitis initially, it should be where you start your treatment and then re-X-ray, because often X-rays lag behind what you actually have as your clinical presentation. We had lots of, lovely, nice people working with us, and certainly the bit I found most enjoyable were the health economics that worked alongside us, because they actually gave a very realistic slant on it all, because at the end of the day, we work for the NHS. We don't just have money that we can throw at things willy-nilly. It is all cost-driven. And they actually looked at the cost-effectiveness of providing custom orthotic footwear. And actually it proved that if the footwear costs between 82 and 671, which for a pair of diabetic shoes, to be fair, is quite cheap, and they were only moderate or high risk, it was cost effective. And if they were between 671 and 859, it was cost effective in the high risk. So these are people that have not ulcerated or have no problems with their feet other than their risk factors, but it proved cost effective. And that's because the cost of treating these patients once they get a problem is an ongoing cost and can be quite expensive. And certainly if you do get deformity of the foot, which I'll look at in a moment, that ongoing cost can be quite extortionate. However, although it's a nice recommendation, I do wonder in our current health economic climate whether we're going to be providing shoes for people that have not yet run into problems. Because in my utopia where I'd love to live, that would be marvellous. But the reality of it actually happening, I believe, is going to be quite slim. The other side of that is actually getting patients to wear our beautiful orthotic shoes when they haven't got a problem might be quite challenging also, because they're not the sexiest. And if you think, well, do you know what, I can get away with wearing my own shoes, you're probably going to chance it. So it's an interesting cycle to go through. But it was certainly from a cost point of view, it just proves how expensive diabetic foot ulcers are. Excuse me. So then we looked at Charcot. Now, I don't know how familiar, as I'm guessing most of your TVNs are, with the Charcot foot, but a Charcot can start as a simple fracture and then actually progress on to be a Charcot foot. It's often red, warm, there's often swelling, there may or may not be deformity, there may or may not be pain. So it's kind of one of those vague, put it out there, what could it be scenarios. Often we have differential diagnoses of DVT, gout, cellulitis, and generally there's an underlying Charcot there. So the advice was that there should be no non-weight bearing until assessed by the Multidisciplinary Foot Service, then be treated in a non-removable offloading device. The temperature of the foot should be monitored with serial X-rays taken. It's generally deemed to be quite an uncommon occurrence. However, in clinical practice, I see it on a daily basis in several patients. It's not as uncommon as we would like to believe. Unfortunately, I think there's a lot that we still misdiagnose and get at late presentation. But it's said that there's 3 per 100 people in diabetes who develop a Charcot. Early diagnosis is essential in these individuals if you want to keep the foot as normal shaped as we possibly can. Excuse me. And if the Charcot does then become deformed, so it doesn't fit in a normal shoe, then the likelihood of secondary ulceration is significantly increased. The likelihood then of amputation is also increased because they can become severely deformed. And this is one of my current patients. He's a 27-year-old type 1, so he's quite young. He goes back to that kind of young age bracket. And he presented at A&E in March last year with a swollen ankle. And it was x-rayed and deemed normal. We started seeing him in June. His x-rays weren't normal. And by December, even those who aren't x-ray savvy can see that that calcaneum has got a nice duck beak fracture to it as a result of an undiagnosed Charcot foot. He was assessed for a DVT, he was treated for cellulitis. Don't get me wrong, his diabetes control is appalling. He is completely needle phobic and injects probably every second day because that just about keeps him out of DKA. Doesn't want an insulin pump because his eyes are now not good enough that he can actually manage an insulin pump. In March of this year, you can see that actually that calcaneum has sort of stabilised best that it can, but this young man is never going to walk normally again. His likelihood of amputation is quite high because it isn't going to take much for that, what's now a heel spur, to cause more problems, and the likelihood of him fracturing again is going to be incredibly high. So our young patients, because we deem that they are in control of their diabetes and they're doing well, unfortunately they don't always get the care and attention that our 60, 70, 80-year-olds that we think are at increased risk get. The diabetic cast is ideal to prevent deformity because once you get the deformity, trying to get footwear to fit these feet is incredibly difficult. And certainly the gentleman on the top right, you can see the width of that foot is huge. Even made to measure footwear, trying to keep the pressure off that area, which is huge, is incredibly difficult because he's walking through his midfoot. We're not designed to walk through our midfoot. And I think the gentleman at the bottom, his foot almost looks a bit like a crab. But again, trying to get shoes even that we've made to measure to fit him long term, we end up then getting ulcerations because it's very difficult to offload him effectively. So when we talk about risk, we're talking about risk assessment. A low-risk foot is a diabetic foot with no risk factors except callus alone. They should have annual foot assessment and ongoing education. Education. Does it make any difference? Probably not, but if we've told them, at least they should have some empowerment, even if they don't listen to what we say. Moderate risk is one risk factor, so it may be deformity, so they may not be able to fit their foot into a normal off-the-shelf shoe. They may have neuropathy, or they may have non-critical limb ischemia. These individuals should be referred to podiatry, to the Foot Protection Service, for a new assessment. And as part of NICE, we've put timelines on this, because it's all very well and good identifying something, but if nobody does anything with it, nothing will ever happen. So they should then be seen within 6 to 8 weeks with a follow-up in 3 to 6 months. This is where it gets a bit more complicated. So the high-risk foot, so they have 2 risk factors. So they may have had previous ulceration or amputation or renal replacement therapy, which is something that we've put in as a new adjunct as part of NICE, because those on renal replacement therapy do very poorly. If they get a problem with their foot, their outcomes generally are significantly worse than those that are not. And I think part of that is because it often is heels that become a problem. Then we've got neuropathy and non-critical limb ischemia, or neuropathy in combination with callus and or deformity. Non-critical limb ischemia in combination with callus and or deformity. So you can see these conversations got a little bit complicated at times. Those individuals should be referred to the Foot Protection Service for an assessment within 2 to 4 weeks, because their risk of a problem occurring is high. They should then be followed up. Those with no immediate concern, 1 to 2 months, and then followed up 1 to 2 weekly, as deemed necessary by the healthcare professional that's assessed them. Active diabetic foot, so that can be an ulceration, spreading infection, critical limb ischemia, gangrene, or suspicion of an acute Charcot. They should be referred to the diabetic foot clinic or the Foot Protection Service within 1 working day, and triage within 1 working day. So rather than saying within 24 hours, which is all well and good if it comes in on a Friday afternoon, you're never going to achieve it. So it's within a working day, and then should be triaged as to how urgent it is. You only need to look at the pictures I've shown you of the ulceration, that some of those are more urgent than others as to how quickly they need to be seen. And that's where your accuracy of description of the wound is vitally important, to try and give that individual who cannot see it the best chance of getting that individual in a timely manner. Obviously, if it's limb or life-threatening, those individuals need immediate admission to secondary care services. And we still see these. These are not something that you've pulled out the ark. These are things that we're still seeing on a weekly basis, unfortunately. Patients that present very late. So to manage the diabetic foot, you need all of these things. So you need the infection controlling. You need to ensure that you've offloaded. You need to ensure they've got adequate blood supply. You need to actually have the wound controlled, because if they've got a wet, macerating wound, the surrounding tissue's never going to do well. You need to educate them on what is expected of that patient. It's not all just to us as healthcare professionals. The patient has to take some part in this journey as well. They need to know what we expect of them and what they should be doing. Also, I'd like to think we need to control their diabetes and actually get better control of their diabetes. Sadly, when we looked at it, there's no evidence that suggests that good glycemic control heals things better. But anecdotally, if someone has good diabetes control, you would generally see that wounds do heal better. We're talking about quite a small percentage of the population. Excuse me. We're talking about approximately 5% have got an ulcer at any one time, and 15% that have been through that journey, remembering that 40% will re-ulcerate within a 12-month period of healing. But there is a small percentage out there, although when you do the foot clinics, it feels like everyone and his mother has the problem. And something that I thought was quite interesting when the health economics looked at the diabetic foot is actually the risk cycle, because I think this helps to put it into perspective. So if you're low risk, that's great. But once you move from low risk, you can still get an ulcer if you're low risk, but you then directly go to be high risk. You can be moderate risk and still get an ulcer, but you then go to high risk. You never go backwards. So once a problem's occurred, it's only going to get worse. So you can then be that high-risk patient with an ulcer, but you can then have a minor amputation that will lead to another minor amputation and another minor amputation, because we can take 10 toes off and other bits of bone and goodness knows what within that foot. But then also you've got the risk of then a major amputation, which might be a below-knee amputation. But there's nothing stopping that below-knee amputation becoming an above-knee amputation. And actually the worst-case scenario in all of this is that you become a double amputee, whether that be below or above. But the circles that some of our patients go round, they're going round in these for several years, just having bits chopped off as piecemeal surgery to try and conserve the foot best we can. So the challenges for implementation, they're huge. Capacity of the foot protection service and the multidisciplinary foot service in lots of centres is not there to see the actual volume of patients that are coming through the door. Also, trying to adhere to the waiting times that NICE has set can be hugely challenging. Not everybody has a foot clinic every day within their centres. We don't. Integration, so the effectively and timely communication between different healthcare settings, so between primary and secondary care, agreeing to local pathways and policies. The centralisation of vascular services has had a huge impact on some. The training and competency, so that ongoing staff turnover, recruitment, and then backfill for training. Recommendations for research. Where do you start? Because lots of it needs researching. But to do research, you often need good multi-centre to achieve this. And unfortunately, we're still losing more legs than we should. 80% are preventable, and we're losing more legs than we used to. 135 diabetic amputations a week in the UK. Thank you.